let's discuss about diabetes in pregnancy. As all of us know, what happens in diabetes? There will be hyperglycemia, right? There will be hyperglycemia. Then why there is hyperglycemia in pregnancy? The reason for this is, in the pregnancy there will be insulin resistance. There will be insulin resistance, and this insulin resistance will result in hyperglycemia. The reason for insulin resistance is some hormones like placental lactogen. Human placental lactogen, and this is the main hormone which causes insulin resistance, and some other hormones like progesterone, estrogen, cortisol. All these hormones can result in insulin resistance that ultimately result in hyperglycemia. Insulin resistance is maximally seen between 24 to 28 weeks of gestation, right? Because during this time insulin resistance will be maximum, and that results in hyperglycemia. Let's see what happens when there is hyperglycemia. When there is hyperglycemia, you see, as all of us know, when there is hyperglycemia in the in the maternal blood, this glucose levels will be transferred to the fetus as well. That means glucose levels in the fetus will increase, right? Due to increase in the glucose levels, it leads to secretion of insulin, right, in the fetus. As all of us know, insulin is required for growth of fetus, and that results in macrosomia. Insulin decreases surfactant production, and that results in increased incidence of respiratory distress syndrome. Increased incidence of respiratory distress syndrome. After birth, what happens is, after birth, the connection between mother and fetus will happen, right? The connection between mother and fetus will be lost. Due to this loss of connection, there will be hypoglycemia, which will be aggregated by insulin resistance. Which will be aggregated by increase in insulin levels, right? So basically there will be increased insulin levels in the fetus. After the loss of connection between fetus and mother, the glucose levels will be decreased, and this will be aggregated by increased insulin present in the fetus. And moreover, due to increase in glucose levels, placenta will undergo hydropic changes, and this results in increased disparity between the supply and demand of oxygen. This results in increased disparity in the supply of oxygen. This results in increased disparity between the oxygen supply and oxygen demand. See, this diabetes in pregnant women is of two types. One is gestational diabetes. One is overt diabetes. And we have so far discussed about gestational diabetes. All the things that we have discussed so far is about gestational diabetes. That is, what is overt diabetes? Overt diabetes means a female who is already diabetic patient will become a pregnant. Already diabetic female will become pregnant. So what is the main difference between these two diabetes? See, in overt diabetes, what happens is, we will see congenital anomalies. We will see formation of congenital anomalies. What is the reason for this formation of congenital anomalies in overt diabetes? You see, in gestational diabetes, hyperglycemia is maximally seen between 24 to 28 weeks of gestation because of insulin resistance. Whereas in overt diabetes, hyperglycemia is seen from the beginning of gestation. That means from the first day of gestation. Whereas in gestation diabetes, hyperglycemia is seen maximally between 24 to 28 weeks. See, when there is hyperglycemia from the beginning, what happens is, you will see, as well first organogenesis will take place. Then after development of further development of organs takes place. If there is any defect in first organogenesis, then that results in congenital anomalies. See, by the time of 24 to 28 weeks of gestation, organs would have already formed, but whereas in overt diabetes, as the hyperglycemia is present since the birth, since the first day of gestation, it results in congenital anomaly. Let's see how it is formed. As well first know, hyperglycemia it results in formation of free radicals, right? Due to formation of free radicals, it results in damage to the organs and results in congenital anomalies, right? So whereas in gestation diabetes, this 24 to 28 weeks of gestation, the organs would have already formed, so it won't affect much. But whereas when it comes to overt diabetes, as the hyperglycemia is present since the first day of gestation, it results in congenital anomalies, right? So most common congenital anomalies that we see is cardiovascular congenital anomalies greater than CNS, right? In cardiovascular congenital anomalies, what we see is ventral septal defect, atrial septal defect, transposition of great arteries, and hypoplastic left heart, coarctation of aorta. Among these, ventral septal defect is the most common, right? When it comes to CNS, neural tubal defect, meningocele, encephalocele, right? Then the most specific anomaly seen in diabetes is caudal regression. This is the most specific congenital anomalies of diabetes. But you see, caudal regression is very rare. That you should remember. So CNS, CVS. Then moving to skeletal anomalies. Skeletal anomalies. The skeletal anomalies that we see here are caudal regression. As I told you, caudal regression is the most specific congenital anomaly. Caudal regression syndrome and agenesis, sacral agenesis. So these are the two congenital anomalies that we see when it comes to skeletal anomalies. So caudal regression syndrome, sacral agenesis. Next, moving to renal anomalies. Renal agenesis, cystic kidney, duplex ureter, These are the congenital anomalies that are seen in renal system. Then move to GIT. In GIT, you will see duodenal atresia, anal atresia, rectal atresia. These are the congenital anomalies seen in GIT.